Okay, this is page 281, and I want to start with a very simple concept. Let me put this in a broad context you can relate to. Many of us have heard of people who have asthma. And in asthma, which is very common, their airways constrict. It's hard for them to breathe. And the medication they give them is they give them a spray to inhale, which is called a bronchodilator. So the problem with asthma is the airways are constricted. The treatment is to make the airways dilate. Now, that's the setup. Before I come back, I'll come back to that in a moment. What have we learned about when blood vessels constrict? When somebody has generalized arterial or vasoconstriction, what does that do to the resistance of the ability of the blood to flow through the vessels? It increases resistance. Imagine a water faucet with a hose. The water's on. When you constrict the hose, it's harder for the water to flow downstream for where you're constricting it. You've increased resistance and you've reduced flow downstream. All right? Similarly, bronchoconstriction, constricting the airways, increases airway resistance, AR, airway resistance. So just as blood vessels constricting causes vascular resistance, constricting airways increases airway resistance. And if you increase that airway resistance, you constrict those airways, that reduces airflow. Again, it works absolutely identical to vessels constricting. Now, what can cause airways to constrict? Parasympathetic, autonomic motor neurons constrict, sympathetics dilate. Histamine constricts airways, and so does nicotine. Now, this is interesting because what effect does histamine have on blood vessels? It dilates blood vessels, but it constricts airways. I'm sorry, the world's not always so straightforward. Histamine makes vessels dilate, which lowers peripheral resistance and drops your blood pressure. But histamine constricts airways. Now, you know people who have allergic reactions carry around epinephrine, adrenaline, EpiPen. Now, histamine makes blood vessels dilate. What does epinephrine do to most blood vessels? Constricts them. We've just now learned that histamine makes airways constrict. What does epinephrine do to airways? Dilates them. Can you see why epinephrine is the exact reverse of histamine? And that's why it's given for allergic reaction. Yes, histamine dilates vessels, adrenaline constricts them. Yes, histamine constricts the airways, adrenaline dilates the airways. It's the bronchodilator. So that's what we wrote. Sympathetic motor neurons and epinephrine are bronchodilators. When you dilate the airways, it lowers airway resistance and improves airflow. The concepts that we spoke of in blood flow are identical to those in airflow. Now, on the next page, 282. So, in our limited time, let's just remind you of how we breathe. In a nutshell, how we breathe, in goes the good air, out goes the bad air, is an application of something called Boyle's law. If you've had chemistry, you should have learned it. Boyle's law says that there is an inverse relationship between volume and pressure. That if volume increases, pressure decreases. Let's show you what we mean. Imagine if we had a bottle with air molecules in it. Right? Got air molecules. Now these molecules are bouncing around and they create a certain air pressure, certain pressure inside this bottle. Okay, we got it closed off. All right? And now imagine we stretch the wall of the bottle bigger. We've got the same number of molecules now in a bigger volume. What happens to the pressure? It goes down. Isn't that intuitive? You've now got the same number of molecules in a larger space, so the pressure inside the bottle goes down. On the other hand, now let's take this bottle and compress it smaller. I've taken the same number of molecules and compressed them into a smaller space. What happens to the pressure inside the bottle? It goes up. That's Boyle's law. Well, this is basically how our breathing works. Okay, first I will demonstrate with myself. All right? When you contract your respiratory muscles, diaphragm muscle and intercostal muscles between the ribs, you do this. The chest gets bigger. And then you relax those muscles. The chest gets smaller. We've just said that if you enlarge your volume, your chest volume in this case, what will happen to the pressure inside your chest and lungs? It will go down. And then when you relax those muscles and your chest gets smaller, the pressure increases. Let's just see how this works. The diaphragm muscle, when it contracts, enlarges the volume of the chest from top to bottom. Here's why. The diaphragm muscle in the relaxed state, when the diaphragm muscle is relaxed, it actually arcs upwards like this. It kind of arcs upwards. That's when it's relaxed. Now, when the diaphragm muscle contracts, what does the word contract mean? Gets shorter. When it gets shorter, it becomes a straight line. Ever hear that expression? What do we call the distance between the shortest distance between 2 points? A straight line. So the diaphragm goes from being arced upwards to a straight line. Can everybody see when it does that, the volume of the chest from top to bottom has now increased by this much? So the chest volume is now larger, and that's going to cause the pressure to go down. The intercostal muscles, the contraction of those other respiratory muscles, like those between your ribs, they enlarge your chest from side to side and from front to back. Overall, the contraction of the diaphragm and the intercostal muscles enlarge the chest, causing the pressure inside to go down. Now, if it starts out atmospheric, if you open your mouth right now and you're not breathing, that means the pressure inside your lungs is the same as the air pressure. No air is flowing. There's no air flowing in or out. So now when you enlarge your chest, the pressure in your lungs becomes less than atmospheric, subatmospheric. And that creates a suction that literally sucks the air in. It's very much like an accordion. An accordion or a bellows is as you stretch the accordion wider, it draws air into the bellows of that accordion as you enlarge it. Right? Then you push in on the accordion and it forces the air out. So that's all we're doing is we're creating a suction. So just think of inhaling sucks. That's what I wrote on 283. During inhalation, I wrote, air is sucked into the lungs. Your respiratory muscles contract. That increases your chest volume. According to Boyle's law, if the volume increases, the pressure inside decreases. This is called a decrease in alveolar pressure. A decrease in alveolar pressure. And air flows into the lungs until the pressure in the lungs returns big to atmospheric. So inhaling sucks. Now we wrote that since inhaling of air involves creating a suction, a negative pressure, negative meaning less than atmospheric, that sucks the air in, normal pulmonary ventilation, normal breathing is called negative pressure breathing. That's what they call normal breathing, negative pressure breathing. Now, I'll come back to that point momentarily. On the next page, 284, so how do you exhale? It's just the reverse. When you, the way we exhale is we relax our respiratory muscles, our chest volume becomes smaller, and that raises the pressure inside of our chest and lungs, making it greater than atmospheric, forcing the air out. Basically, I always say that the way when we exhale, air is blown out. We blow out the air. It blows. When I mention this when I teach anatomy, I always say inhaling sucks and exhaling blows. Inhaling, you create a suction. Exhaling, you blow it out. You raise the pressure in your lungs, and that blows the air out. So, and then I always point out that you should always make sure you suck when you're supposed to suck and blow when you're supposed to blow. You shouldn't be sucking when you should be blowing. You should be blowing when you should be sucking. It's all just a bunch of issues of sucking and blowing. Don't think about it. All right? So, inhaling sucks, exhaling blows. We blow the air out under a high pressure. Now, why this is relevant, again, we're limited in time, so I can't fully explain this. But in the future, when you deal with ventilators, they call the ventilators or respirators that are commonly used IPPBs. Has anybody ever heard that term? An IPPB stands for an intermittent positive pressure breathing device. Because with a ventilator or respirator, you don't create a suction drawing in the air in. Instead, that air is blasted in at a greater than atmospheric pressure. That's called positive pressure. We don't have time to talk about it. But it's not the exact opposite of normal breathing. And being on a ventilator or respirator is really nothing like normal breathing. Because basically the way I try to have students imagine being on an IPPB is take an air hose from a gas station. There's not many gas stations that have air hoses anymore. Find one that has it, stick the air hose in your mouth and turn it on. That's what an IPPB does. It blasts the air in under high pressure. That is not the way normal breathing works. Normally, you create a suction. You may create a subatmospheric pressure that sucks or draws the air in. You don't blast the air in under high pressure.
So when you come off the respirator, is that why you take such shallow breaths?
There's a lot of things going on. Okay, I just don't have time to talk about it, but it is very different from normal breathing. All right, now we're going to jump ahead because again we're limited in time to page 293. Page 293. This is page 293. And whatever we're skipping, it's not that what we're skipping is unimportant. It's actually quite important. We just don't have time to cover it. But anyhow, quantifying pulmonary ventilation. Now, what we want to set this up, what we want to do is to be able to express the amount of air we inhale each minute. Right? Do you think that's important to know, how much air you inhale each minute? Well, if you're not sure if it's important, it is important. Now, before I explain how we evaluate the amount of air we inhale each minute, I want to draw a parallel for you. Do you remember learning this for a test we just took? Cardiac output. There are two major factors that affect cardiac output. And incidentally, what is cardiac output? It's the volume of blood ejected by each ventricle each minute. Right? It's the amount of blood ejected per minute by each heart. We normally eject about 5 liters per minute. Is that right? So, what determines how much blood our heart ejects each minute? Two things. How fast is it beating? Heart rate. And how much blood did it eject with each beat? Stroke volume. Never stroke them all hard. Everybody okay on that? Then that tells you how much blood is ejected per minute. Now, how do we figure out the amount of air we inhale each minute? The way we write it is dot V. You'd say, what's dot V? V means volume, and dot means per minute. That's the way they write it. I didn't create these abbreviations or terms. This is what part of clinical science is about. So that means volume per minute, or what's commonly just called minute ventilation. Now, the amount of air we inhale each minute depends upon the frequency that we're breathing, how fast, how slowly, and something called the tidal volume, which is written V sub T, tidal volume. What's the tidal volume? That's how much air you inhaled with each breath. Now, we wrote that pretty typically at rest, you breathe, your typical breathing rate at rest is about 15 breaths per minute. That's very likely. In the books, they usually say 12. I wrote 15. Now, why did I write 15? Because usually, you're wondering what I'm doing. When a patient becomes aware that you are watching them breathe, we all become self-conscious and we start breathing faster. So in the moment you start to count the breathing rate of your patient, they start to breathe faster. So even though if you were counting, if you were able to just measure it without them being aware that you're doing it, it'd be about 12 breaths per minute. The moment you as a future nurse start to look and count their breathing, it's going to be more like 15. You can't help it. So that's how fast you're breathing. The tidal volume is the volume you inhaled with each breath. And we normally inhale 500 milliliters of air with each breath. Half a liter. Now, I like that term tidal volume. That's kind of cute. You know why? You know how we talk about the tide of the ocean? And the tide comes in, and the tide goes out, and the tide comes in, and the tide goes out. And that's what our breathing is. The air goes in, and the air goes out. The air goes in, and the air goes out. Just like the tide. So that's called your tidal volume. And we normally at rest inhale 500 milliliters with each breath. Now, obviously, just like with cardiac output, this heart rate and stroke volume are what we learned is what happens at rest. But we know during exercise, these change. Similarly, these change in breathing during exercise. But we're just talking about at rest. So notice that if we breathe 15 breaths per minute, and we inhale 500 milliliters of air with each breath, can you see that the breath units cancel out, and the result is milliliters per minute. 15 times 500 is 7,500 milliliters per minute, or 7.5 liters per minute. Can you see how similar this is to cardiac output? Cardiac output was how much blood was being ejected per minute by the heart. Minute ventilation, which is what this is called, is how much air you're inhaling each minute. Incidentally, you should be exhaling the same volume of air each minute as what you're inhaling. Because if they don't match, if you're inhaling a different amount than you're exhaling, something's going to be really wrong real soon. Okay, so it's got to be working right. Now, what if a normal minute ventilation is about 7.5 liters per minute, then if somebody is breathing significantly less than that, we say they're hypoventilating, underventilating. They're not breathing adequately. On the other hand, if at rest, you're looking at them at rest and they're breathing like this, something's wrong. You shouldn't be doing that. Incidentally, there are conditions where that happens. Something called, you'll learn about this, called Kussmaul breathing and diabetes and ketoacidosis. Kussmaul rapid breathing. You don't have time to get into it. But anyhow, hyperventilation is too much breathing each minute. Now, another fascinating concept is dead space. Dead space is written as V sub D, volume, dead volume. Now, what's dead volume? I wrote what it is right up here. Dead volume, I'm not referring to the space between your ears. I mean, that's not dead space. It is the volume of air that doesn't reach your alveoli. In other words, it's the air in the conducting division of your respiratory system. So you might say, I don't get that. So here, I've highlighted that when you inhale air, it goes down your throat, down your trachea, your bronchi, bronchioles, and eventually it reaches your alveoli. The only place where oxygen can enter your bloodstream and carbon dioxide can leave your bloodstream is at the alveoli and pulmonary capillaries, at the microscopic level. There is no exchange. There's no exchange of air with the gases, with the bloodstream in your throat or your trachea or your bronchi. So oxygen's not entering your lungs or entering your bloodstream across your trachea or throat. Only at the alveoli is there an exchange of gas. Which means, even though we've just learned that you typically inhale 500 milliliters of air, in fact, the last 150 milliliters of air that you inhale is up here in your trachea and throat, in what's called the dead space. And I wrote that on the next page. On 294, we wrote that the dead space volume is normally 150 milliliters. Thus, with any inhalation, the last 150 milliliters of air doesn't get down to the alveoli. It's up there in your throat and your trachea. So while it's true, you inhaled 500 milliliters of air with that breath, we would actually really like to know not how much air entered your mouth, but how much air actually reached your alveoli. Because that's the air that did you any benefit, not the air that's up in your throat and trachea. So, we can take that into account, and this is called .V sub capital letter A as a subscript. All right? This is called alveolar minute ventilation. Alveolar minute ventilation. Without the A, it's called minute ventilation. This is called alveolar minute ventilation. How much air made it down to the alveoli each minute? So here's what we're going to take into account, the dead space. So what does it say? Okay, how much air reaches the alveoli? It depends upon how fast you're breathing. Let's say 15 breaths per minute. But this time, what we're going to do is we're going to subtract your tidal volume of 500 milliliters per breath, and we're going to subtract out the fact that the last 150 milliliters of each breath is up here in your throat and trachea, not in your alveoli. So, 500 milliliters per breath minus 150 milliliters with each breath, which is in your dead space. 500 minus 150 is 350. So now it becomes 15 breaths per minute times 350. So yes, you're still taking in 500 milliliters of breath. But now we've subtracted out part of that breath because it doesn't get down to your alveoli. So 15 times 350 is 5,250 milliliters per minute, which is 5.25 liters per minute. And you know what I find absolutely amazing about that number? That's what a normal cardiac output is. Coincidence? I don't think so. So the amount of air that actually reaches your alveoli each minute is essentially similar to the normal cardiac output amount of blood ejected per minute, after we took into account that dead space. Now, there's another thing I can mention. Well, we'll get to the other thing about the dead space in a moment. Now, let's jump ahead. Again, it's not like what we're skipping is unimportant, but we're going to go to page 300. Page 300. This is page 300. Now, we want to talk about how they express the amount of oxygen and carbon dioxide, not only that's in the air you breathe, but the amount of oxygen and carbon dioxide that's in your lungs, and the amount of oxygen and carbon dioxide that's in your bloodstream. Now, first let's think about what air is. Now, if you ask most people, what's air mostly made of? You know what most people will say? Oxygen. Are they right? No. What is air mostly made of? Nitrogen. It's 79%, close to 80% nitrogen molecules, N2. Oxygen makes up about 21% of the molecules in air. It's really 20.8%. We won't even worry about carbon dioxide. It's really, really small. So that's what air is. Now, the way they express the amount of oxygen and carbon dioxide in the air and in the lungs and in your bloodstream is they use a concept you learn about in a chemistry course called partial pressure. I don't know if anybody remembers partial pressure, but I will explain it. If we had a container with different molecules, different gases in it, right? It's closed. So there's a pressure in here. These molecules are bouncing around, just as we said earlier, and they're creating a certain pressure. All right? Whatever pressure that is, there's a total pressure due to all these gases. If we knew, let's say the blue molecules were oxygen, that if I knew what percent of the molecules were oxygen, and I knew the pressure inside the bottle, if I multiplied what percent of the molecules were oxygen times that pressure, then I would have the partial pressure due to oxygen. So here's what that means. You'd say, I don't get that. We said that oxygen makes up 21% of the molecules in air, or 0.21. What's the atmospheric pressure here at sea level? 760 millimeters of mercury. That's the atmospheric pressure due to all the molecules in the air. So if we multiply 21%, which is what proportion of the air molecules are oxygen, times the atmospheric pressure of 760, 21% times 760 is 160 millimeters of mercury, or 164. You'd say, I don't get that, I'm really mixed up. What we're saying is out of the 760 atmospheric pressure, 160 out of that 760 is the part due to oxygen. That's called the partial pressure of oxygen. Who's making up most of the partial pressure of the atmospheric pressure? Nitrogen. 600 millimeters out of 760 is due to nitrogen, because it makes up almost 80% of the molecules. So the way we express the concentration of gases in the air and in our lungs and in our bloodstream is it's always expressed as a partial pressure. That's just the way they express it. All right, so I'm not asking you to memorize any numbers here. I just want you to understand what a partial pressure is. You learn this concept in a chemistry course, whether you remembered it or not. Okay? Charlie's nodding, so it's fresh in her mind, so she knows that that's, of course, she also studied a lot of chemistry. But, okay, but anyhow, now, I want to go to page 304. Oh my gosh, scary. Scary. Page 304. All right, now it looks scary, but it won't be that bad. Page 304. Now, what this shows up here on the top, your top left, is it indicates the concentration of gases in the air we inhale. The capital letter, P stands for partial pressure, capital letter I is what we inspire, what we inhale. These are the standard ways of writing these things, incidentally. This is not my cute little way of doing it. This is the way it's done clinically. And you'll notice, what do they show as the concentration of oxygen that we normally inhale? 160, that's what we just showed you. That was the partial pressure of oxygen. How do you get that? 21% times 760 is 160. That's where that came from. So that's what they would normally say. The partial pressure of oxygen in our room is 160. And then here it gives the CO2 and the water vapor, and of course the biggest number is nitrogen, because most of what's in the air is nitrogen. Okay, now, let's look at the alveoli of our lungs. What is the concentration of oxygen and carbon dioxide in our lungs? Do you think this is important to know? If you're not sure, the answer is yes. First off, we use that capital letter A, subscript, for alveoli, just like we used it for alveolar minute ventilation. Capital letter A always means alveoli. So what is the oxygen level in our alveoli of our lungs? 100 millimeters, and you've just memorized it, because you need to know it for the final. You need to know what a normal oxygen level is. The normal CO2 level, not quite as nice a number as 100 for oxygen. You still need to know it, it's 40. That's the normal CO2 level in your lungs. Now, the first thing I want to explain then is you'll notice that if the oxygen that you inhaled was 160, in your alveoli of your lungs, can you see a decrease to 100? Does everybody see that? Now, I'm not asking you to memorize that number. I am asking you to memorize this. But it did decrease. Conversely, carbon dioxide, there was very little carbon dioxide in the air, but in the alveoli, it goes up. Why? Well, it's really obvious. All right, you say, how's it obvious? Here it's diagrammatically, it shows the pulmonary circuit. Here's the right pump, pumping the blood through the pulmonary circuit to the left pump. Now, we know the blood that's being carried to the lungs in the pulmonary arteries, low in oxygen and high in CO2. Now, what happens as the blood goes through the pulmonary capillaries around the alveoli, the carbon dioxide that's in the blood enters the alveoli. Can you see why that's going to raise the CO2 levels? The carbon dioxide that was in your blood is entering the air sacs. So obviously, whatever air you inhaled is now gaining carbon dioxide in the alveoli from your bloodstream. On the other hand, you know how you had all this high amount of oxygen that you inhaled? That oxygen is entering the bloodstream. So it's coming out of the alveoli and entering the bloodstream, so clearly the oxygen level is going to go down. However much it was when you inhaled it, it decreases as it flows into your bloodstream. Does that make sense? Obviously, it's that oxygen you inhaled entered the bloodstream. The CO2 left the bloodstream and it entered your alveoli. So of course these levels change. So that explains those numbers. Now, once we've got this blood going through the pulmonary veins, and even now pumped by the left pump through the systemic circuit, we can measure the oxygen and carbon dioxide levels in either the pulmonary vein, or the way it's usually done, because you can't get to the pulmonary vein, is it's usually just measured in our systemic arteries. The symbol that we use for systemic arteries is a small letter A. A small letter A stands for systemic arterial blood. That just means they draw blood from any systemic artery. And they measure these oxygen and CO2 levels. When they do, they're called ABGs. What's ABG stand for? Arterial blood gases. I knew she'd know. Okay, that's the arterial blood gases. And they do this all the time in the hospital. Now, I want you to memorize these numbers. But what do you notice about those numbers? They are the same as these numbers. Because this equalizes. This just is in equilibrium. So in fact, when they measure the arterial blood gases, if the oxygen level in the arterial blood were lower than normal, they know it's lower than normal in your lungs. Because these are always the same. If this oxygen level in your arterial blood is lower than normal, why the hell would the oxygen be lower than normal in your arterial blood unless your lungs aren't working right? And so whatever the O2 and CO2 are in your systemic arteries, that's what it is in your lungs. So if the oxygen level is lower and the CO2 level is higher than normal, look, if you've got a breathing problem, somebody's got asthma, emphysema, pneumonia, if you're having trouble breathing, you don't think that's going to reduce the amount of oxygen in your blood? You think somebody with pneumonia or emphysema has got... ever see people with emphysema carrying around an oxygen tank? Because their lungs are just crummy. They're falling apart, their lungs. So these are the same. So that's the good news. Now, I'm not going to ask you, normally I would if we had time, but I'm not going to ask you to memorize the oxygen and CO2 levels in the venous blood. We do use a small letter V to stand for systemic veins. And when they draw blood, and you know in the hospital, the people who draw blood from veins are called phlebotomists, because phleb means veins. So they analyze the blood, they do that hematology blood work, all those blood tests, And they also will record they can measure what the O2 and CO2 levels are in the venous blood too. Those are less important than the arterial blood gases. But these are the values. So I'm not going to ask you to know. But there is one last thing that I want to show you about this diagram, which is really amazing. And you're going to think I'm making a mistake, but I'm not. This is the air that you exhale out your mouth. We use a capital letter E to represent the exhaled air, or expired air, means the same thing. And here's what I'd like you to notice. I'd like you to notice that the oxygen level in the air you exhale is higher than in your alveoli of your lungs, and the carbon dioxide in the air you exhale is lower than the CO2 levels in your alveoli of your lungs. Do you see what I'm saying? I'm saying that the air you exhale has more oxygen in it than in the alveoli of your lungs. How is that possible? This is the dead space, right here. So I will read it and then explain it to you. The air, right below the diagram, exhaled air is actually a mixture of the air that was down in your alveoli and the air that was up in the throat. That is the dead space. Now, if you're still not sure what that means, here's what that means. When you exhale air, let's say out your mouth, right? I inhaled air, now I'm exhaling it. The first air that you exhale right out of your mouth was the air in your throat. Did it ever lose oxygen? No. It never lost any oxygen. It never gained any carbon dioxide. It has the same amount of oxygen in your throat and CO2 in your throat as what's in air. Because unlike your alveoli, the air that went down to your alveoli, some of that oxygen entered the bloodstream and it gained CO2. But the air up here in your throat, in the dead space, never lost oxygen and never gained CO2. That's the first air you exhale out. The last air you exhale out with each breath is the air from deep within your alveoli that has lost oxygen and gained CO2. Does everybody follow that? So that's why the air you exhale actually is a mixture of the two. And this explains one more really neat thing. This is why mouth-to-mouth resuscitation works. Had you ever thought about this problem? If all you were doing was blowing into somebody else's mouth, the victim's mouth, your dirty air, if all you were doing was blowing in air low in oxygen and high in CO2, how's that going to save them? But that's not how it's working. It's beautiful. Think about it. As you blow into the victim's mouth, the first air that comes out of your mouth was the air in your dead space, in your throat, that has as much oxygen in it as out here in the atmosphere. It never lost oxygen, never gained CO2. That air that you're blowing into their mouth is the first air that enters their mouth and goes deep into their alveoli. The last air out of your mouth that's, quote, low in oxygen and high in CO2 from deep in your alveoli, that's the last air that comes out of your mouth, is the air that fills their dead space, their throat. It works perfectly. And that's why it works. Now, we're not saying that the air you're blowing into their mouth doesn't have bacteria and cooties. But in terms of oxygen and CO2 levels, the first air out of your mouth, which was the air that went deepest into their alveoli, is as high in oxygen as the air right here that you're breathing right now. And that's why mouth-to-mouth resuscitation works. And this is why I love physiology. Because it basically allows us to analyze everything and see how it all works. So that it's not just, it's more than just memorizing numbers and more memorizing terms. It's really seeing how we can take the human body and really break it apart and see how it's working. All right, so that's a neat diagram. Now, we've got just a few last minutes, so let's jump to page 325. This is good, because if we're jumping to 325, this is the end. Okay, page 325. So I guess everything in between was worthless. You just skipped it. But I think you can see there's more to respiratory physiology than, in goes the good air and out goes the bad air. Now, with the last remaining time, I want to tell you a little bit about what's called acid-base balance in the body. A very, very important clinical subject you will all hear more about, and one of the more confusing subjects in your future clinical courses. There are 4 categories of acid-base problems. And these 4 categories are actually written right here in this chart. They are respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Now, I mostly want to focus on the respiratory acidosis and and metabolic acidosis. I'm going to focus on the acidosis. I'm going to tell you briefly about all 4, but I really want to focus on these 2 types of acidosis. Now, respiratory acidosis is not actually totally new, because it was actually described back in section A. If you don't believe me, you'll look. All right. Imagine somebody is having trouble breathing. There are many causes of breathing problems. Difficulty in breathing, asthma, emphysema, tuberculosis, pulmonary edema, all kinds of things. So what do we call that when you're not breathing normally? Hypoventilating. Now, if you're hypoventilating, and here, let me just look right here first. Hypoventilation leads to both hypercapnia and hypoxia. You'd say, what? Let's look at the word hypoxia. Hypoxia has the root hypo, which means low, and oxia, oxygen, low oxygen. Does it make sense that if you're having trouble breathing, you have less oxygen? Okay, that sounds good. What's hypercapnia? That is the clinical word for increased carbon dioxide levels. If you're having trouble breathing, you're not getting enough oxygen in, and you're not getting the carbon dioxide out. So it's accumulating. Now, so this increase in CO2, called hypercapnia, forms carbonic acid. Anybody remember us learning that before? Because carbon dioxide, which you should now think of as the major source of acidity in the entire body, that's the major source or cause of this acid, combines with water, of which there's no shortage of in your body. You're 60% water, forming carbonic acid. So in other words, anytime somebody is having trouble breathing and carbon dioxide accumulates, whenever carbon dioxide accumulates higher than normal, the amount of carbonic acid becomes higher than normal. And that's called respiratory acidosis. Now, just to look at the opposite of this, not as important. At the bottom of the page, what if instead of somebody was underventilating, what if for whatever reason they're hyperventilating? So if they're hyperventilating, they're getting rid of carbon dioxide faster than normal. There is a normal rate, a normal amount. And if they're lowering the amount of carbon dioxide in their body, they're lowering the amount of carbonic acid. So they're actually becoming alkalotic. There's a normal CO2 level in your body, and there's a normal carbonic acid level. If you're not breathing enough, there's too much CO2 and too much carbonic acid. If you're over-breathing, you're not supposed to be doing this when you're just sitting in a chair. If you are, your CO2 and carbonic acid levels become lower than normal, and you become alkaline. You don't have enough carbonic acid. So it's just the reverse. Now, on the last page, 326, what is, on 326, metabolic acidosis? Metabolic acidosis, as I wrote, is the accumulation of any acid other than carbon dioxide or carbonic acid. If you have a buildup of any acid other than the CO2 carbonic acid, that's called metabolic acidosis. I'll give you 3 quick examples. Lactic acid. That's not carbonic acid. Lactic acid, we know, can be formed in our muscles when they're not getting enough oxygen. Ketoacids. Ketoacids are formed, for example, during diabetes. Uric acid. Gout. So in all 3, and let's just use ketoacids as an example. So if somebody has ketoacidosis, that's a type of metabolic acidosis. It's not a problem of breathing. Breathing problems cause a buildup of CO2 and carbonic acid. This is a buildup of an acid formed from a disorder of metabolism. And so these are called metabolic acidosis. So we don't have time to explain what's going on. I will just briefly mention, I won't ask you about it, the most common cause of metabolic alkalosis is vomiting. You'd say, what? Well, look, you have all this hydrochloric acid in your stomach. Is that right? Ever hear you got hydrochloric acid? I'm looking around for any nods. Nobody's nodding. All right. If somebody vomits it out, you've just lost acid from your body. That acid was supposed to be in you. So now that you've lost all that acid, you're in a state called metabolic alkalosis. You're too alkaline because you lost too much acid. The last thing I'll just show you, and we're not going to hold you responsible for it, but it's pretty neat. Let's look on page 319. Again, if we would have had time, we would have gotten into this. This is page 319. Let's just show you what's here. So on page 319, this is a lab form from the Pulmonary Function Lab. And you'll notice here, what does it have? V sub T and F. Yeah, you'd say, yeah, what's that? Tidal volume. And what's a normal tidal volume? 500 milliliters with each breath. F, that's the frequency. What's the normal frequency of breathing? 15 breaths per minute. What's the normal pH of our blood? 7.4. Between 7.35 and 7.45. If it's less than that, you're in a state of acidosis. If it's greater than that, you're in a state of alkalosis. This is not new. This was section A. If you don't believe me, look. What's the normal oxygen level in our arterial blood? 100. You're going to memorize that for the test. What's the normal partial pressure of CO2 in our arterial blood? 40. These are called your ABGs, your arterial blood gases. These are monitored all the time. I'll get one quick way of measuring this is a pulse oximeter. You ever see this little device you put on the finger? And it estimates, it's an estimate. It's not as accurate as actually drawing blood. But it estimates oxygen levels in the blood. That's called a pulse oximeter. All right, now, so that's how that works. And then just to look at this, you can actually know which type of acidosis or alkalosis you have just by knowing 2 things. 2 things. You need to know the pH of the arterial blood, and this is printed right on the form incidentally, and you need to know the partial pressure of CO2 in the arterial blood. Now, what's the normal pH? 7.4. What's the normal carbon dioxide level in arterial blood? 40. That's all normal. So let's just consider 2 things real quickly. What if somebody's got a pH of 7.2? 7.2 means you're acidic. You've got acidosis. It's lower than 7.4. Now let's imagine they measure the carbon dioxide level, and the carbon dioxide level is higher than 40. Let's say it's 60. Let me draw a line straight up. Here's acidosis. Here's CO2 hypercapnia. And what does it say they've got? Respiratory acidosis. The reason why they're acidic is there's too much CO2, carbonic acid. That's called hypercapnia. And the last point. What if you measure the pH? It's 7.2. They're acidic. You look at the carbon dioxide level, and the carbon dioxide level is either normal or even less than normal. Then it's metabolic acidosis. Because if the carbon dioxide level is normal, or even lower than normal, and they're acidic, then they're not acidic because of too much CO2. If the CO2 level is normal, they must have metabolic acidosis. They must have some other acid that's causing them to be acidic, like ketoacids or uric acid. This is known as acid-base analysis.
Again. Hey, we can put a different song and that's more. Yeah.
I missed the whole thing.